Hi, my name is Asif Rahman, and I will be presenting our paper titled Phenotyping with Prior Knowledge Using Patient Similarity. This work was done with my colleagues Yale Chang, Brian Conroy, and Manan Su at Philips Research North America. So machine learning models are often data inefficient and can fail to generalize to new cases. This is largely driven by the heterogeneity of the patient population. In other words, there could be subgroups of patients that respond very differently to interventions or have different underlying diseases. A single task model, therefore, may not generalize well to some subgroups. On the other hand, training a model on small subgroups of data is inefficient, and the subgroup a patient belongs to may be unknown at inference time. Moreover, depending on the subgroup, the same feature can have very different risk profiles. One way to develop subgroup-specific models is by using prior knowledge or side information found in electronic medical records. The problem is that most of the relevant knowledge in EMR can't be used because of constraints on data availability or the cost of acquiring the data. For example, the ICU unit type, comorbidities, and future interventions may only be available during training, but not at evaluation. So how can we distill relevant knowledge from the EMR to learn subgroup-specific models and improve interpretability? We present prior knowledge learning, which is a mixture of experts model with a similarity constraint on the output of the gating network. The similarity constraint pushes the gating network to group similar patients to the same expert. The similarity matrix is defined using side information like the unit type, comorbidities, future interventions, and vitals and labs. The practical impact of the similarity loss term is that experts learn to specialize on subgroups of similar patients, and we get to use the vast amount of side information available in EMRs, which is only needed during training. For example, when patient similarity is defined by whether the patient is in the step-down unit, experts learn to specialize on the unit type. In this example of predicting hemodynamic interventions, PKL groups almost all step-down patients to one of the experts, whereas a mixture of experts model without the similarity constraint equally distributes step-down unit patients across the experts. We also show that PKL can be used for cohort discovery. When patient similarity is defined by vital signs and laboratory measurements, the PKL model discovers clinically meaningful phenotypes when predicting hypoxemia. Remarkably, these subgroups have also been described in patients with acute respiratory distress syndrome. To summarize, the PKL model is a mixture of experts model and an alternative to multitask learning. PKL learns more clinically meaningful subgroups compared to unsupervised models like GMMs. And importantly, side information is only used during training. Thank you.